Hello everybody. So I just want you to know that it gets more and more exciting the farther and farther we go down the GI tract. So now we've gone out of the mouth and we're into the esophagus, and now we're going to talk in chapter 54 about esophageal problems. So in your book they start out mentioning gastroesophageal reflux disease, but I do want to mention another term, and that term is achalasia. And achalasia is a rare disorder that makes it very difficult for food and liquid to pass into the stomach. It results from damage to nerves in the esophagus, and it prevents the esophagus from squeezing food down into the stomach. It can be caused by an abnormal immune system response. So it requires a medical diagnosis. It is treatable, but it does cause backflow of food into the throat, so regurgitation and chest pain and weight loss. So this terminology is also called cardiospasm. So I want to show you up here on this picture. Here is the cardiac sphincter. If you can see it in the top right. And then there is the pyloric sphincter. So the cardiac sphincter is the lower esophageal sphincter that it describes on page 1087 in your book. So this is connecting the esophagus to the stomach. So your lower esophageal sphincter is also known as your cardiac sphincter. Then you have another sphincter called the pyloric sphincter that is at the bottom of your stomach, that goes from your stomach into the duodenum. So again, in this picture, there is an upper esophageal sphincter as well. And here is the lower esophageal sphincter. So again, in the book, they start talking about GERD, gastroesophageal reflux. So this is a chronic disease of reflux, and all that means is regurgitation or backflow of food that is trying to be swallowed and deposited in your stomach. It's going back up into the esophagus. And it's the most common upper gastrointestinal disorder in the United States. It occurs most often in middle age and older people. So again, it's backward flow of stomach contents into the esophagus. And if you remember from talking a little bit about the stomach, it's not healthy for acidic stomach contents to be regurgitated up into the esophagus all the time. So symptoms that are related to exposing the esophagus, again, all of this is mucosal lined. So if the esophageal mucosa is constantly irritated because of the effects of gastric or even duodenal contents, the esophagus is going to get inflamed. So again, remember where the upper esophageal sphincter are and the lower esophageal sphincter. So the upper esophageal sphincter again is at the proximal end of the esophagus, up here by the trachea and the throat or the pharynx. And the lower esophageal sphincter is at the gastroesophageal junction down here. So with GERD, there's excessive relaxation of that lower esophageal sphincter. excess relaxation of the lower esophageal sphincter. So that allows reflux of gastric contents into the esophagus and exposes the esophagus, that mucosa, to those acid secretions from the stomach. People who are overweight or pregnant have an increase in intra-abdominal pressure, and that can contribute to that reflux. Also, lying flat at night decreases peristalsis, and we don't have the benefit of gravity when we're laying down, so the esophagus can also be exposed to acid at that time. Hiatal hernias, which we'll talk about later, also increase a person's risk of gastroesophageal reflux disease because of the increased intra-abdominal pressure. We've talked about H. pylori, and that is a bacterium that can cause gastritis and poor gastric emptying, which can also lead to gastroesophageal reflux disease. So over time, the refluxed material returns to the stomach via saliva, peristalsis, and gravity. The inflamed esophagus can't eliminate the refluxed material as quickly as a healthy one, so the length of exposure increases with every reflux episode. So just think about that. If that gastric acid is building up and staying in there for a length of time, then it's going to be harder and harder on the esophagus. Hyperemia, which is increased blood flow, and erosion of the esophagus occur in response to that inflammation. So then we talk about Barrett's epithelium. So if you remember from anatomy, columnar epithelium is a thicker, because it's in columns and not cubes, or not, it's not squamous, which means flat. This is columnar epithelia, which grow instead of normal squamous cell epithelia, the flat stuff, in the lower esophagus. So if we have that columnar epithelium, it's very thick. And so during the healing process, sometimes the body substitutes that Barrett's epithelium. So people get Barrett's esophagus, and it sounds good because it's thicker. And there's a thumbs up there. It says because it's more resistant to acid and it supports esophageal healing. But it is not normal. It's not a normal epithelium, so it's actually premalignant, and it's associated with an increased risk for cancer in people who have had GERD for a long time. So if you hear the terminology Barrett's esophagus, they're talking about that columnar epithelium that is building up in there because of the constant irritation, and it's just a protective measure that our esophagus takes to protect itself from that gastric acid. But it's a bad thing because it's premalignant. So you're probably going to see that again on a test somewhere. Other complications of esophageal reflux are esophageal strictures. So people get fibrosis and scarring that can also occur when the esophagus is trying to heal itself from constant irritation from the gastric acid. People can get asthma, laryngitis, their teeth can decay, they can get cardiac disease, they can get aspiration pneumonia, and actually hemorrhages from GI bleeding. People have, just so you know, esophageal strictures also cause difficulty swallowing. So again, that's called dysphagia. So if gastroesophageal reflux is not controlled, then there are a lot of other complications to that disease process, as you can see. So other factors, such as eating large meals and delayed gastric emptying, can cause reflux. Smoking and alcohol can influence the function of that lower esophageal sphincter, the cardiac sphincter. An NG tube can cause a decrease in lower esophageal sphincter function because it keeps the lower esophageal sphincter open, and so therefore it allows contents to flow backwards along the tube. So again, it's that tube will keep that open and allow the gastric acid to escape from the stomach back up into the esophagus. So even though NG tubes can be helpful, they can also be, in a way, harmful. So signs and symptoms of gastroesophageal reflux disease. If I can find chart 54-1, key features, that's on page 1088. So signs and symptoms: dyspepsia and regurgitation. Again, what is dyspepsia? Dyspepsia. If you don't know what dyspepsia is, it's just a big word for indigestion. Abdominal discomfort, feeling uncomfortably full, nausea, burping. A person can get worsening symptoms if they bend over or if they strain. If the pain from gastroesophageal reflux is severe, the pain can radiate to the neck, jaw, and back. So sometimes people mistake GERD for heart pain, but it's much better to err on the side of caution than not to go to the emergency room if somebody is having that chest pain that radiates to their neck and their jaw. They need to go to the ER and see if it is the heart or is it esophageal reflux disease. Sometimes they're the same types of symptoms. So atypical chest pain is thought to be caused by stimulation of pain receptors in that esophageal wall and esophageal spasm. So patients should not ignore this. It can mimic angina. So an assessment by a nurse or a doctor should be done very carefully. So again, those key features, and you will see these again, those are on page 1088. Something else that you want to pay attention to on that same page is table 54-1, factors contributing to decreased lower esophageal sphincter pressure. So there they have a lot of different foods, like for instance, spicy, fried, fatty foods and caffeine decrease the lower esophageal sphincter pressure and contribute to GERD. So that's something that you will see again as well. I think there's another chart on page 1090. Let's see if I can find that. It's actually in the reading on page 1090. It says teach the patient to limit or eliminate foods that decrease lower esophageal sphincter pressure and irritate inflamed tissue, causing heartburn, such as peppermint, chocolate beverages, carbonated beverages. The patient should also restrict spicy and acidic foods such as orange juice, tomatoes, until esophageal healing can occur. So that is on page 1090, and you'll see some of that again as well. So signs and symptoms, more signs and symptoms, I should say. Pain after meals, drinking fluids and taking antacids and sitting upright generally alleviates the signs and symptoms. Generally. So after eating, eructation, so belching up stuff, flatulence, bloating, those are all can be symptoms of GERD as well. Respiratory issues. Remember a while ago I mentioned asthma, but people can get bronchitis, crackles, wheezing, chronically cough at night. So possibly the person has been aspirating. So again, terminology. All of these blue, there's a bunch more blue terms in this chapter. So some of them we need to look at. Regurgitation, backflow into the throat. Water brash. That's on page 1089. Water brash is a sensation of fluid in the throat, but there's no bitter taste, so it's reflux salivary hypersecretion. Eructation, again, belching. Flatulence is gas. Flatus is, pardon my terminology, but it's the same as a fart. Flatus is a fart. Dysphagia is difficulty swallowing, and odynophagia is painful swallowing. So you always want to be aware and assess for those symptoms in your patient with gastroesophageal reflux. So how do we diagnose GERD? There's no definitive diagnostic test for GERD. They do barium swallow studies where a person drinks barium solution and then they have x-rays taken. And basically the barium shows up because it's radiopaque. The barium swallow studies can help show a hiatal hernia or a stricture. An EGD, again, that stands for esophagogastroduodenoscopy. It's a scope with a lens. They put it down the throat and they can directly look at the esophagus and the stomach and the duodenum. They can get biopsies, and they do use sedation whenever they go down somebody's throat. Sometimes they will numb the throat also. I don't really know any gastroenterologists that do that around here, but if you're ever working with someone who has had an EGD, just make sure before you offer them anything to eat or drink post-procedure that they have a good swallow reflex. They can do pH monitoring. That's the most accurate method. And of course, what they would do there is take a sampling of mucus from the esophagus, and if it is acidic, that means there's stomach contents, because there should be no acid in the esophagus. So there's a small catheter put through the nose, usually into the distal esophagus, down by where the lower esophageal sphincter would be. and they take just a sample and then check the pH of it. They can do gastric emptying studies where the patient eats a meal mixed with dye, and imaging is performed over the next few hours to see how the stomach is emptying. So that's called a gastric emptying study. Patients can also keep track in a diary of what they have been eating and what activities they've been doing, what symptoms they've had, and that can also help in the diagnosis of gastroesophageal reflux. Your book also talks about gastric manometry. So I will put this back up in class because this is actually a swallow study, fluoroscopy that I mentioned the other day. And I kind of wanted you to see how that works. So if you remind me, I will put this back up in class so you can actually see a swallow study. So what they do there is they put a barium substance or a substance that is radiopaque. They put it in. They can put the powdered in liquid or puddings, or they also have something like icing that they can put on a cracker, and then have the person chew and swallow those different consistencies, and they check to make sure that it's going down the right pipe, basically, in real time as they swallow. Okay. So managing GERD, for most patients, GERD can be controlled by nutritional therapy or changing their lifestyle, or also some drug therapies. Nutrition therapy is used to relieve symptoms in patients that have relatively mild GERD. So healthy eating habits and small frequent meals, limiting intake of fried, fatty, or spicy foods, limiting caffeine, and sitting upright for an hour after meals all of those things can help with management of GERD. So again, limiting or eliminating foods that decrease lower esophageal sphincter or cardiac sphincter pressure and irritate inflamed tissue causing heartburn, like peppermint, chocolate, alcohol, fatty foods, like fried foods, caffeine, and carbonated beverages. Restrict spicy foods and acidic foods. And I want to point out again on page 1088, table 54-1 in your book, has a listing of factors that contribute to a decreased lower esophageal sphincter pressure. So again, you will see that again. Smoking and alcohol use should also be avoided because these also decrease lower esophageal sphincter pressure. So maybe we could try to get people into a smoking cessation program or alcohol treatment if they need it and desire it. So lifestyle changes. On page 1090, chart 54-2, patient and family education, health promotion and lifestyle changes to control reflux is where this came from. So elevating the head of the bed for sleep. We actually used to put people's beds, like at home, We'd get big wood blocks and tell them to put their head of the bed up on wooden blocks. Right side lying position to promote gas exchange. Swallow frequently to clear the esophagus. And of course that only works if they don't have dysphagia, because a lot of time if they have dysphagia, that's trouble swallowing. So swallowing frequently isn't a good thing to tell them, I suppose. Weight reduction, because again, obesity and abdominal obesity increases intra-abdominal pressure. So in order to cut down on that, they could have some weight reduction. Avoid constrictive clothing, lifting objects or straining or bending over after they eat, that kind of thing. And CPAP is useful for obstructive sleep apnea and GERD symptoms in obese patients. So getting to drug therapy for GERD, you're probably relatively familiar with some of these. There are three main categories: antacids that are effective for occasional episodes of heartburn discomfort. They elevate the pH, meaning, meaning that stomach acid is acidic. So if we give them an antacid, it's going to elevate the pH or make it more alkaline. With antacids, the length of action is short, and it increases lower esophageal sphincter pressure, and therefore is not given for a long term, not used for long term. Some antacids contain aluminum hydroxide or magnesium hydroxide. So magnesium hydroxide would be Maalox or Mylanta. Liquid forms are preferred because they coat the esophagus to provide better pain relief. People need to take antacids an hour before and 2 to 3 hours after a meal. There's a substance that is an antacid called Gaviscon that forms a thick foam that floats on the top of gastric contents. Gaviscon. The next category of drug therapy is histamine blockers. Some of the biggest histamine blockers that you might have heard of are famotidine or Pepcid and ranitidine or Zantac. And then there's also cimetidine, which is Tagamet. So what histamine blockers do is decrease acid. They're long-acting. They reduce gastric acid secretions and promote healing of inflamed esophageal tissue. So when you get to your test, there may be a question about, like, when should these be taken? The best time to take histamine blockers is at bedtime, but you won't necessarily see that in the clinical area. I don't know that they give these types of medications necessarily at bedtime. Another medication class that you are probably familiar with is proton pump inhibitors, and you've probably heard of Protonix before. There's several of them. Omeprazole is Prilosec, is the trade name for that. Pantoprazole is Protonix. Esomeprazole is Nexium, and lansoprazole is Prevacid. So proton pump inhibitors are the main treatment for severe GERD. So these are long-acting. They inhibit gastric acid secretion. by affecting the proton pump of the gastric parietal cells. So go back in we talked about parietal cells in the assessment. So what do those secrete? Do you remember? Proton pump inhibitors can be taken once or twice daily. Many times they're only given once a day. Protonix and Nexium can be given IV for short-term use. Actually, most of these should be used only on a short-term basis. In the hospital, we use proton pump inhibitors to prevent stress ulcers. And we'll talk about, when we talk about the stomach next, in the next section, there's peptic ulcers. People can get peptic ulcers due to stress. So hospitalizations are very stressful. So in order to prevent stress ulcers from happening in hospitalized patients, we give them Protonix. They promote rapid tissue healing, and we use them only for a short term because long-term use can cause community-acquired pneumonia and GI infections like C. diff. There's also a lot of research that's been done concerning liver damage. So you may see this information again. Just remember the proton pump inhibitors can cause pneumonia, C. diff, or liver damage. So if that's the case, if they can cause liver damage, one of the things you could do is check a person's lab values and look for elevated liver enzymes. So again, Nexium, Protonix, Prilosec, and Prevacid are all proton pump inhibitors and are the main treatment for severe GERD, and they are long-acting and can prevent stress ulcers. Right. So surgical management for GERD. So there is a procedure called a laparoscopic Nissen fundoplication. It's a minimally invasive procedure and is a standard surgical approach for severe GERD. A person usually has to continue taking anti-reflux, antacids, and proper nutrition therapy because the rate of recurrence of GERD is high. The big thing with post-op for these Nissen procedures is to prevent respiratory complications. So you're going to see that again. So make sure, again, these are post-op people, and they should be using their incentive spirometry, and they should be turning, coughing, and deep breathing post-operatively. So that shouldn't be anything new anyway. So, but just so you know that we need to prevent post-op respiratory complications if a person has had this Nissen fundoplication or any other post-op procedure, actually. So they talk about the Nissen on 1091. So I'm mentioning it here, but we will talk about it again in the section for hiatal hernias, because that is also a treatment, surgical treatment for hiatal hernia as well. And here's a picture of the Nissen, how they do it. The picture is on page 1093 also. So if you look at that, how they do it, they just basically wrap a bunch of the fundus of the stomach around the lower esophageal sphincter and suture it together. Kind of interesting. So next in your book is hiatal hernias. And hiatal hernia pictures of those are on 1092. So there are two major types of hiatal hernias. One type is a sliding hiatal hernia, which is the most common. And then there's a paraesophageal or rolling hernia. So the esophagogastric junction and a portion of the fundus of the stomach slide upward through the esophagus hiatus into the chest. So when does it occur? Usually during when we change position or when intra-abdominal pressure increases. So of major concern, again, with hiatal hernias is that there is that esophageal reflux and the complications that go along with that reflux. So hiatal hernias, they, like I said, there's two main types, and they can slide or else they roll. Rarely, however, will they get twisted. And if you remember me saying the other day, intestines can twist or they can telescope into each other. Hiatal hernias can actually also twist, and that's called a volvulus, if you remember. But rarely does a volvulus, or that twisting and an obstruction, occur. With rolling hernias or paraesophageal hernias, the GE junction remains in its normal intra-abdominal position, but the fundus rolls through the esophageal hiatus and into the chest beside the esophagus. So GERD is not usually a problem because the lower esophageal sphincter remains anchored below the diaphragm. So look at that rolling hernia. That's on the very right-hand side of page 1092. Rolling hernias. The GE junction remains in its normal intra-abdominal position. So you can see that. But the fundus rolls through the esophagus and into the chest beside the esophagus. So again, in that picture, that rolling hernia, GERD is not usually a problem because the lower esophageal sphincter, the cardiac sphincter, continues to be below the diaphragm. Now, in something like that, if you look at that, an obstruction could occur and a volvulus could occur. Like that could twist and become obstructed. So here are the different types again. You can see the normal stomach, a sliding hiatal hernia, and a rolling hiatal hernia. So how do we assess them? Heartburn is associated with sliding hiatal hernias. So let's look at that again. Let's look at that. I'll go back to that picture. So this is the rolling one, and there's not, this lower esophageal sphincter is down here, so we don't have a lot of problem with reflux. On the other hand, in the middle, that sliding hiatal hernia, the stomach does go up through there, and we do have a problem with heartburn, and reflux is a problem. So make sure that you can differentiate between these two when it comes to the test. You need to know the difference between them. Okay, I'm going to go back down. So assessing a barium swallow study with fluoroscopy is the most specific test for identifying a hiatal hernia. EGDs usually aren't done, but they can be performed to view both the esophagus and the gastric lining. But they don't necessarily use an EGD to diagnose a hiatal hernia. So what do we do if somebody does have a hiatal hernia? They slide and they roll. So what do we do for them? So there is non-surgical management. Sliding hiatal hernias are most likely treated medically. So sliding hiatal hernias, if you remember, are the ones that the lower esophageal sphincter comes above the diaphragm, so we have trouble with indigestion. So what will we treat that with? Chances are we're going to be treating that with some antacids or some proton pump inhibitors, right? So some kind of drug therapy. We could also follow guidelines of GERD as far as the nutrition part of it. And then lifestyle changes, such as losing weight or stopping smoking or reducing or quitting alcohol. We can also do surgical management. We already talked about the Nissen fundoplication. That's commonly used. We can use a transthoracic approach. An NG tube is inserted during surgery and remains in place for several days. This is a bigger type procedure where they have chest tubes in place, more pain medications, that type of thing. So I'm not going to go into that extensively, but all of that is on page 1093. If you look on page 1093 also, there's another nursing safety priority action alert. And it's saying the most important role of the nurse in caring for a patient with a hiatal hernia is health teaching. Encourage the patient to avoid eating in the late evening and avoid foods associated with reflux. Teach the patient and family that the patient should follow a restricted diet and exercise regularly. Reducing body weight is beneficial because obesity increases intra-abdominal pressure and worsens both the hernia and the symptoms of reflux. And then it goes on to, it says teach about positioning, and you can read about positioning. So post-op care and post-op complications. Post-op care, again, for the paraesophageal repair, For post-op care, again, you're going to have to make sure they do their incentive spirometry, their deep breathing, to prevent atelectasis and pneumonia. They may have a feeding tube. So initially the NG is going to drain dark brown with old blood. The drainage then becomes yellow and lighter. We have to make sure we check that NG for every 4 to 8 hours for proper placement. We want to make sure that it doesn't become dislodged, because if we would have to reinsert it, we could damage the fundoplication. Make sure the person has good oral hygiene, fluid replacement. They will slowly progress to a near normal diet. They'll need stool softeners, and we definitely don't want to stress the incision. So we like to keep decreased intra-abdominal pressure. So on this particular slide, post-op complications of these procedures include dysphagia. So we want to make sure we supervise their first oral feeding. Temporary dysphagia after these procedures is common. At some time, they may have to have a dilation of that fundoplication if it's too tight. There's also something called gas bloat syndrome, where the patient is unable to voluntarily belch. So we need to make sure that we avoid carbonated beverages and eat gas. We don't want them to eat gas-producing foods like high-fat foods. We don't want them chewing gum or drinking through a straw, because all of those increase and promote gas in the stomach. There's also something called aerophagia, which is air swallowing. So we want to teach people to eat and drink slowly, chew all their food thoroughly, and take time to relax consciously after they eat their meals. Post-operatively, we want them to frequently change their position, and we want them up walking soon afterwards. Esophageal tumors. Although they can be benign, most esophageal tumors are malignant. Most arise from the epithelium and are squamous cell carcinomas. Most squamous cell carcinomas of the esophagus are located in the upper 2/3 of the esophagus. So squamous cell carcinoma. Tumors grow rapidly because there's nothing that limits their extension. There's lymph tissue there, so that it can easily spread by the lymph nodes. Tumors are usually large and well established when they are diagnosed. More than half of esophageal cancers metastasize. Risk factors, they increase with age. There's an increased incidence in white males and Alaskan natives. I don't really know why that would be, but primary risk factors for esophageal tumors are smoking and obesity, untreated GERD, excess alcohol, Barrett's esophagus. I told you about Barrett's esophagus a while ago, the columnar epithelium. The squamous epithelium is from at the esophagus that is damaged by the acid from the stomach, is damaged, and in the healing process, Barrett's epithelium, the columnar tissue, is formed as a protective measure, but it's precancerous, so that is not good. Other risk factors are lack of fresh fruits and vegetables and gender. So males are more frequent. Signs and symptoms of esophageal tumors. It's a silent tumor in early stages, meaning there are no signs and symptoms. So there are a few observable signs in its early stages. By the time it causes symptoms, it usually has spread extensively. The most common symptom of esophageal cancer is dysphagia, but it may not be present until the esophageal opening has gotten much smaller. It's initially associated with swallowing solids, particularly meat, and then progresses rapidly over a period of weeks or months to difficulty swallowing soft foods and liquids. Patients usually report a sensation of food sticking in the throat or a substernal area. There's also odynophagia. I think I mentioned that terminology before. That's painful swallowing. Steady, dull, substernal pain may radiate. Occurs most often when patients drink cold liquids. Severe or persistent pain often indicates tumor invasion of the mediastinal structures. So what's the mediastinum? What's in the mediastinum? The heart, the thymus, lots of structures in the mediastinum. So how do we diagnose esophageal cancer? Barium swallow studies with fluoroscopy. Again, they may see the margins of the tumor there. Esophageal ultrasound gives a definitive diagnosis, but they will do a fine needle aspiration, which is similar to a biopsy, to examine the tumor tissue. An EGD can inspect the esophagus, and again, they can get specimens for tissue sampling and for staging the disease. So they stage cancers, and you'll learn about that in 435. PET scans are positron emission tomography, where they identify metastatic disease. And PET scans are used for all kinds of different cancers, not just esophageal cancers. As far as the patient themselves, there's high anxiety with the diagnosis, so you have to pay particular attention to their psychosocial needs. It's distressing, for one thing, to not be able to swallow, not be able to eat. They have a fear of choking, a fear of aspirating. So ask about coping and how they cope, or how they, what resources do they have to help them if they have this diagnosis of esophageal cancer. Treatment. Non-surgical, again, I'm not going to get into a lot with cancer because you'll go through all the cancers in 435. But again, chemo, radiation. Chemo is only a little bit effective for esophageal cancer. Radiation is only moderately effective. Chemo is usually given in combination with radiation, but surgery is the most definitive intervention that is used. They can go in and do an esophageal dilation. It can be performed to temporarily relieve the dysphagia. And so dilators are used to tear the soft tissue and widen the esophageal opening. So they do that when they perform an EGD. The problem with those is that there's always a risk of perforation. And if the dilation doesn't work, they can also use stents. But if they use stents to keep the esophagus open, there's also always a risk for bacteria getting into the bloodstream. So something they have to be very careful about. So again, I don't want to get into, there's just a lot to this. I don't want to get into a lot about cancer, but surgical management, just so you know, they can do an esophagectomy, which is removal of all or part of the esophagus. They can do an esophagogastrostomy, which is removal of part of the esophagus and the upper part of the stomach, and then the stomach can be pulled up, or a section of the jejunum or colon can be used as a conduit or a detour. But there's always risks to any kind of surgical procedure, like respiratory complications, especially since this is, in the throat. Fistulas, abscesses. These are very lengthy procedures depending on the degree of the cancer. So postoperatively, there's lots of possible complications. So nursing assessment skills have to be very sharp. But respiratory for an esophagectomy. So we monitor for atelectasis and pneumonia, fluid volume overload, so many things. So lots to think about with esophageal cancer. So medications that we can use, some of the chemotherapy that we can use, and many of the drugs that we use, even antibiotics, have the side effect of photosensitivity. So if there is a side effect on any medication that you give any of your patients, if it says photosensitivity, make sure that your patient is aware of that, and make sure that they know that they can burn very easily. So again, here's treatment, surgical treatment, esophagectomy, esophagogastrostomy, pyloromyotomy, and colon interposition. So again, a section of the colon can be substituted for the esophagus. And I don't remember if your book has a picture of that or not. So yes, on page 1099, they show a colon interposition. So where they take an actual piece of the colon and substitute the colon for the esophagus. So 1099, nursing safety priority. These action alerts. Respiratory care is the highest post-op priority for patients having an esophagectomy. So all of these nursing safety priorities, you should probably in every single chapter be reading all of those because they're all really important. Page 1098, if you just kind of glance over there, I'm not even like skimming it. I just looked over there, and in italics it says, teach the patient about regular turning, coughing, and deep breathing, and having chest physiotherapy. Emphasize the crucial nature of post-op respiratory care. So just remember that when we're working with somebody's throat in any way, shape, or form, that is going to be, the respiratory and breathing, airway clearing, all of that is going to be top priority for them. So, whenever someone has an esophagectomy or any other surgery like this, they could have a NG tube. So NG tube care, monitoring the drainage that's coming out. Again, an NG tube, just think of where that is going. Nasogastric. So that means it's going through whatever their surgical incision, there are some anastomoses there. In other words, where it's connected, that tube is going through there. So you have to think about that. You don't want anything to happen to that NG tube. You don't want it coming dislodged because you don't want to reposition it. You don't want to irrigate it without an order from the surgeon. And again, if people have an NG tube, make sure that the head of their bed is elevated, because any tube is going to make, if you've got a tube in the stomach and it's going up the esophagus and out the mouth, just think of the anatomy, and stomach contents can follow that tube up and out. And if the patient is breathing, which most patients we hope are, they can aspirate. So respiratory, respiratory, respiratory. And you're going to probably see that again on the test. Not just respiratory, 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 but what are we going to do with that NG tube? So there are tons of risks associated with these procedures. Big ones are respiratory, obviously, and nutritional, and bleeding, and infection, and a lot of other things. So there's just so much. Esophageal diverticula. So your colon can have diverticulum, and again, that's just outpouchings or sacs that are weakened musculature. So just like the picture shows here, there are little arrows pointing out those little sacs. There's a type of esophageal diverticula that is a large diverticula called Zenker's, and older adults tend to get that more often. These diverticula are most often diagnosed by EGD. The symptoms patients report are dysphagia, regurgitation. They have a cough at night, and they have bad breath. So, again, the muscle layer here is weakened and kind of missing. So these things can perforate. And if you think about that, perforation, how if one of these is perforated and the person is bleeding, how are we going to get that stopped? So if a doctor does an EGD, they are performed with very strict care because of the risk of perforation. And here is a picture of what a Zenker's diverticulum looks like. So incomplete or late opening of swallowing muscles can cause high pressure in that hypopharynx and lead to these Zenker diverticula, the most common form of an esophageal diverticulum. So they look kind of strange, don't they? But definitely an outpouching of the musculature. Esophageal trauma. Common causes of esophageal perforation: straining, seizures, trauma, foreign objects, Instruments or tubes, chemical injury like Drano. Don't drink that. Keep that out of children's reach for sure. Complications of esophageal surgery and ulcers. Those are all common causes of esophageal perforation. And see, I have a note to self, table 54-2. And that is on 1101 in your book. So esophageal trauma can perforate or rupture with excessive force. Caustic acid secretions enter the mediastinum. Again, what's the mediastinum and what's in there? Creates problems directly or to the surrounding structures. Chemical injury result of ingestion of caustic substances such as Drano. So what do we do if somebody has esophageal trauma? We assess for airway patency, breathing. Again, this is in their around their airway. So respiratory. We assess for chest pain, dysphagia, vomiting, and bleeding. We keep them NPO to prevent leaking esophageal secretions. Esophageal and gastric suction can be used to rest the esophagus and allow for initial healing of the mucosa. But just remember, if we have an NG tube down to suction, we also, it kind of puts the person at a risk for aspiration. So keep the head of the bed up at all times. Person might have to have total parenteral nutrition or because they need the calories, they need the nutrition to heal. So they need the calories, they need the protein for healing. We want to prevent sepsis, so they will probably be getting antibiotics due to this trauma. They may be getting steroids because we want to decrease the inflammation and prevent stricture formation. They will need pain relief. Can you imagine drinking Drano and having your esophagus eroded? They'll need pain relief, and they may need some topical agent like lidocaine for analgesia. So again, another big chapter with lots of information. There's just so much to this. It's interesting to me, and I am sure that in your career you will encounter people who have trouble swallowing, and GERD it's very common. So again, important information, and I have pointed out a few things that you for sure need to know. Just remember also with the anytime somebody has surgery, those high calorie, high protein foods are needed to heal, first of all. Just another reminder that gravity is the only defense against reflux. So keep the patient sitting upright with feedings, not only post-operatively, but if they have a GERD, if they have esophageal surgery, anything like that. And maybe small meals. If you're trying to keep the pressure inside the stomach lower so people don't vomit or regurgitate, Maybe they shouldn't drink fluids with their meals. Maybe they should drink between meals and eat small, frequent meals and have the fluids, between meals instead of with meals, so we don't fill their stomach up so full and create that intra or that high pressure that causes them to vomit or whatever. So that is like people who have esophagectomies or things like that. We don't want them to have a really full stomach because they'll regurgitate and they need to keep the head of their bed up. So, so much to know, but just really think about when you're going through these chapters, like what are some real big safety issues? And if you think about the esophagus, it's right there. It's right there by your airway. So protect that airway at all cost. So I will see you in the next installment. All right. Thanks so much.